everyone. Thanks for coming today. Before I introduce Dr. Halsey, we just wanted to introduce everyone to our new part-time outreach worker. This is Katie Vieira, and just a little round of applause for Katie. She'll be here all winter. As most of you know, I had the same position for a couple of years, and I learned a ton. Katie's first day was 2 days ago?
Yesterday.
It was yesterday. If you have any problems, go to Katie. She's going to help you sort it out. We're just happy to have her. So we also, as you can see, there's some cameras here today for Dr. Halsey. We have Ann. Thank you, Ann, for taping this, for filming it, and it will be available on MVTV. So without further ado, we have Dr. David Halsey, and obviously he's an orthopedic surgeon from the Martha's Vineyard Hospital. Many of you already know him, and he's going to talk to us today about arthritis and osteoarthritis. So thank you.
Thank you very much. Can you guys hear me okay? Turn that up a little bit more. Maris? Maris? Can you turn it up just a little bit? I'm not going to lean into that the whole time, so let's turn it up a little bit. Well, first of all, thanks for allowing me to be here. That sounds better. And join you for lunch. What a great meal. Oh, it's delicious. It's the best kept secret in town right here. It's really nice to be included. I know many of you, at least by face, more and more by name, and a few by good friends. And thank you very much for stepping up to help bring this material forward for those who couldn't join us here today. Just to sort of introduce myself, and sorry about my back to the crowd back there. I'm here with my wife, Katie. We have 2 grown children. We live in Edgartown full-time, just around the corner on Curtis Lane, and just couldn't be happier with the wonderful, warm reception that Katie and I found in coming to Edgartown. We've been summering here for many, many years, East Chop and around, but when we decided to move here full-time in the fall of 2016, not just one, not just 2, but about 8 or 9 couples just took us under their wing and made sure we got to meet people and felt welcomed. And you know, for a wash ashore, that doesn't happen all the time, right? So I just really want to pass along the gratitude for my wife and I for the welcoming to the community, and it's great to be here and play here and work here and fish here and sail here and all the wonderful things that this environment gives us. So it's nice to be a part of your community. So my specialty is orthopedic. That comes from the Greek. It means straight child. I was a Greek and Latin student at Deerfield and Middlebury, and that really is the foundation of orthopedics, is helping children with injuries, or in fact scoliosis was the big thing back then. So that's the origin of our name, of our profession. We're medical school, 4 years, 5 years of orthopedic residency after medical school, 1 or 2 years of subspecialty fellowship after that. In this case, for me, hip and knee care. And so I really didn't get a real job till I was about 31 or 32. And I'm now 62. So 30 years of practicing the specialty of orthopedics. That's the musculoskeletal system. The greatest thing about my job is that every day I walk into the office, whether it was in my small private practice in little communities in Woodstock, Vermont, and Hanover, New Hampshire, 15 years, or about the same in the University of Vermont on the academic side, teaching, training, learning from our young doctors, or back here now in a community setting. The best part about my job is walking into the room, because I never know who I'm going to see. I could see a 78-year-old person who's struggling with knee arthritis. I could see a 9-year-old who's rolled her ankle in basketball. I could see a 3-day-old child with clubfoot. Or I could be blessed and see, as I did a few weeks ago, a 100-year-old person who's there for shoulder trouble, visiting the island. So the beautiful thing about orthopedics is the diversity of the people you meet and the care that you're able to deliver. And that's why I'm so excited, and people know me know I just love what I do, and that's a blessing, because not every job is as rewarding and as fun as orthopedics. So I could talk about all kinds of things musculoskeletal, but let's talk to Maris and Greg, and thank you both for facilitating and making all this happen. They sort of thought the idea of osteoarthritis would be a good topic, and I can go into a little more depth, of course, on hip and knee, as that's my sub specialty. But if I can, I'm going to start off with just osteoarthritis. And to do that, we need, you know I'm a Latin and Greek scholar, so we're going to start off with the foundation again there. I bet you everybody in the room knows osteoarthritis. You may not know it by name, but you know it by feel, by that morning stiffness, that middle of the day ache in your low back, that debilitating discomfort trying to reach up to grab something off the high shelf. I can't seem to squat in the boat under the deck like I used to. Almost all of that is osteoarthritis. Osteoarthritis by derivation is osteo, bone, arth, joint, itis, damage or inflammation. That's the lecture. We're all done. We'll have dessert now. Osteoarthritis. Now there are over 60 kinds of named arthritis. Arthritis just means damage to a joint. Rheumatoid arthritis, psoriatic arthritis, Lyme arthritis, it goes on and on and on. But 90% of patients who suffer from a joint condition called arthritis have this type, osteoarthritis. So that's where we're going to focus on today. We're going to talk about sort of what's new and what's true. And there's a lot out that's new, and there's a little bit out that's true of what's new. And I hope, in keeping up with, I think, the other series that's going on about myths in medicine and things, this may dovetail pretty well. Just to check in, people can hear me okay if I move ahead? Okay, great. So, with that introduction, here's sort of our flight plan. I'm a pilot as well, and keep a little airplane out at the airport. It's how I used to come and go to the island before we moved here. You got to have a roadmap or a flight plan, and you're not going to reach your destination. And this is a pretty long flight, and I'm not going to do all of this unless we want to. But first, just a little bit of our, meaning yours and my, current understanding of osteoarthritis, the treatment options, and there are two big groups. Living with arthritis as well as you can, curing arthritis so you don't suffer with it anymore. And they're two completely different topics. Can do a little of both today. I'm going to ask you what your pleasure is. I can talk to you a little bit about sort of the advances of what happens when we actually cure the problem called joint replacement. And if we wanted to, I could take a little bit about what we're doing at Martha's Vineyard for joint replacement that's consistent with, quite honestly, some of the best practices in the country now because of the blessing of the great facility, the people who were there, and the collaborative effort that we've got. So that's sort of my flight plan, but you're the passengers on the flight. So you guys get to decide where you want me to focus or spend my time. Everybody got that? That's really the question before you. Do you want me to focus on sort of the science of osteoarthritis, on the treatments that are non-surgical, the ones to help you live well and a vital full life?
Yeah.
Yes.
Yes.
The little piece of that spectrum, that's the fix it so you don't have it anymore. Is there some interest in that or not too much?
Yeah.
A little bit on that as well. And then a little bit about Martha's Vineyard, that's like a slide or two. So we'll get there. So have I got the pulse? We're going to focus on a little bit on the understanding of what it is, because without that we can't really talk articulately about the spectrum of treatment options. Sound okay?
Yep.
Now, I'm actually here for you guys besides the great lunch. So just two or three, I bet you a lot of people, but just a couple of questions from you all. So I'm going to maybe put a couple of people on the spot. Can I put you, sir, on the spot? Well, just a thought. What's the pressing question you hope you might learn about today?
Well, as we get older, one of the things that happens is there is probably somewhat of a lack of understanding when some of this stuff happens. And I think that, our background as doctors is doctors are teachers. And the trick is how do you educate those of us that really don't have a clue what's happening as to, first what to look for, and then how to go about taking the next steps that we have a certain measure of control over where we're headed.
Great. Does that capture a bit for a number of you, sort of that similar question? Okay. Can I put you on the spot? What would be the area you'd like to hear a little bit about?
A Baker's cyst.
Baker's cyst, a specific diagnosis about that? Mm-hmm. Okay. Lots of interest on that one. What's a Baker's cyst? We can chat a little bit about that. If I don't do an adequate job on that, you and I will chat a little bit more independently about, okay? How about maybe one more, another topic, something you wanted to hear about today?
Shoulder pain.
Shoulder pain. Okay. acute or more chronic?
It's just become chronic in the last 6 months or
Okay.
so.
Chronic, so there are more troubles. Okay. Sound familiar to anybody else, probably?
Yeah,
I
like
would think so.
pain management, probably,
Yep,
Yeah.
I would think.
yep, absolutely. Well, that certainly falls into the spectrum, and
How about nutrition to
Yep.
avoid those problems?
well, we're gonna touch on what's new and what's true about that.
Okay.
Absolutely. All right, well, I think we've got the pump primed, and let's go ahead. So here's the basic science, okay? And for some of you, this may be repetitive, and for some it may be new, and like, what the heck's he talking about? But this picture is just a diagram of a sort of your typical anatomy. And anatomy is everything to musculoskeletal physicians, it's everything. Anatomy, the bone and joint. So every joint in our body has these basic parts. A bone rubbing against another bone, in between cartilage, just like you have on the chicken leg when you open it up, the shiny white knuckle on both sides, that's the cartilage, underneath it's the bone. And that bone, cartilage bone, is surrounded by a gristle. We call it the joint capsule. Richly innervated, has lots of nerve endings in it, and therefore is in fact the source of most of the chronic pain of arthritis. Isn't really sort of from the bone, not so many nerve endings, cartilage, no nerve endings, fortunately, but it's the surrounding soft tissues that give the trouble. So that's the basic anatomy. And that could be your temporomandibular joint, that could be your cervical spine, your shoulder joint, your knee joint that produces a Baker's cyst, your hip joint. I mean, they're all the basic fundamental anatomy. Bone on bone with cushion cartilage in between, surrounded by a gristle that keeps it together with lots of nerve endings in it, and inside a fairly thick, gooey fluid we call synovial or joint fluid in the joint. And every joint's got a little. My little finger, last little joint's got a tiny little bit of joint fluid in it, and my hip joint's got a whole bunch of joint fluid in it. It's supposed to. Actually, mine doesn't so much because I have 2 hip replacements because I believe in this stuff. So I just did it for the heck of it. So it changed my life, actually. I was able to get back to pickleball and tennis and sailing and all the fun things I want to do. So that's the basics of osteoarthritis, of a healthy joint. So the disease of osteoarthritis involves all of it. It's not just the loss of the cushion cartilage and wearing it away like the tire tread on your truck or your sneakers. It's not just that the bone gets hard and brittle, actually, in some areas, hard and brittle. Not just that the capsule or gristle around gets stiffened and the nerve endings get irritated. Not that the fluid inside becomes inflammatory rather than anti-inflammatory, which normal joint fluid is. But all of those are impacted. So our nutritional treatments, our pharmacologic treatments, our injectable treatments, our physical therapy treatments, our surgical treatments are all trying to get at those pathologic pain-generating components: bone, cartilage, capsule, and abnormal fluid. Okay? We good on that fundamentals? So that's just 2 years of med school, done. We got that covered. So that's good. Now we'll go on to 3rd year of med school, which is sort of the science behind it. So the articular, that's the fancy word for the 2 surfaces of the bone covered by cartilage, protects the bone ends and allows our joints to slide and glide. Even in utero, our joints move. We're born, they start to move, and then through the rest of our life, 1.2 million cycles per hip, per person, per year, average sedentary society. The old agrarian society where everybody was working all day, walking around all day, 5 times that. Okay? So that's a normal, healthy joint lined with cartilage, good thick fluid inside, less friction, very slippery, comfortable moving joints. We all used to have them. Okay? The problem is that we live on this gravity-laden planet. And if you live on a planet that has gravity, then you will load your joints with every step. Not in outer space, but on land, you load those joints. And from your very first steps, actually, you start the process of wear and tear. Just like a brand new, beautiful truck tire, you roll it off the lot, you start to wear the tread down. Okay? It happens in everyone. Some families faster, with injury certainly faster, with obesity certainly faster, cigarette smoking proven faster. All of those things have an impact on the breakdown. So you need a slippery, smooth, cushioning joint, and you need it well aligned. You want a ball and socket, smooth on smooth. As soon as it becomes rough on smooth, problem, pain. So you'll hear us talk about in the office when we look at x-ray, and we say, look at those bone spurs, or look at that deformity or the change in shape. I'll show you some pictures. That really accelerates the problem of the normal breakdown of aging when you've had an injury or malalignment. Okay, so here's what happens. So remember I said itis is inflammation or damage. This is the cycle that you and I live with, your stiffening shoulders over the last few years, all of us, right? It starts out with some provocateur. I reach for the anchor. I reach to the shelf. I try to get to the pocketbook in the back seat of the car. Something starts off some form of an ouch or an injury. Pain, followed by, I'm not going to move it as much because it hurts, which makes things tighten around the joint, stiffness and capsule. Now the motion's long. Now the joint is tighter, but I got to move it to live. Ouch, and it's a vicious circle that goes around and around. Could be with an injury, doesn't have to be. And quite honestly, fortunately, we're pretty hard on our joints, right? Certainly more in the last 50 years from a recreational standpoint, but before 50 years, physical work, we're very tough on our joints. Very tough. And the more we load them, the more fun we have, and the more we begin to damage the tire tread and wear things down. So I talked about the joint being bone, cartilage, the capsule, and fluid. Well, not surprisingly, there's a lot more to it than that. And when God sort of figured out our joint cartilage, she was brilliant about the whole thing. She decided that I'm going to make it this way. There's going to be bone underneath. There are going to be cells that keep it alive. There are going to be layers of tissue that give it strength, and it's going to be really shiny and smooth on top. Brilliant design. Problem is she ran out of money. On Saturday night of the 7 days, she was working on it, and she ran out of funding. And she could only put cells at the very bottom to keep the cartilage alive. There are no cells for 90% of cartilage. It doesn't really have cells in it that heal things. And it's because of that lack of the ability to heal that we have this problem called arthritis or osteoarthritis. Because if we could heal it like skin or a cut or an ulcer and it heals, you wouldn't have arthritis. You'd have that temporary problem and it'd go away and you're good. But human cartilage after age 8 to 10 loses its ability to heal. That's why we suffer with the problems of arthritis. Yeah, it's pretty young actually. The cells become senescent and don't do their job. And part of what's new is to be able to try to trick those cells or upregulate them or turn them on again to do their job in healing. But the cows, we're not quite there yet. It's not fully baked, the science yet, and the treatments for doing it. So we're still dealing with the symptoms. So the real cause is the imbalance between the breakdown and repair of cartilage starting at a young age, the loss of those cartilage components, the tread gets thinner, the tissue gets stiffer, more stiff, less shock absorption, more stress on the bone spurs form, the capsule gets tight around the bone spurs, it gets inflamed. That's the cycle of osteoarthritis. We okay with that? Those basic ideas? Okay. So let's take a look at it in action. So osteoarthritis, this is a knee, okay? We're looking at the front of the knee, this picture to my right. Kneecap, the end of the thigh bone, the end of the shin bone, the gristly cartilage in between, healthy knee. Picture on the other side looks like my favorite pair of tennis sneakers, right? Worn down, there's potholes in the middle of the road, looks like just before election year. Looks like it's all worn down there, right? And knobby bone spurs around the edge, pushing on the capsule, making those nerve endings hurt. And those are the classic findings. Could be any joint in the body from your neck, your jaw, to your toes. That's just a diagram of what osteoarthritis looks like. So that's the science behind what is this problem we're treating. And I use this a little bit. I'm not sure this is science, so I'm going off science now. But I think the most common medical condition in the world is the upper respiratory tract viral syndrome, probably, right? Skin cancer, unfortunately, is getting pretty close to that, but that's the one that needs procedures. But right behind viral syndrome is osteoarthritis when it comes to prevalence in the world. More lost days from work, more money spent on it by a factor of 1,000 than heart disease. It's far and away the biggest health condition, and we do not know how to cure it. So everything you're going to hear about is how we treat it, treat the symptoms of arthritis, but we don't make it go away. And that's the frustrating part for the scientists who want to solve the dilemma. We're getting there, but we're not there. So the physician in the office, listen to your history, hear about how long your shoulder pain has been, talk about when did you start feeling that lump in the back of your knee. We'll do a physical exam, and then we will almost always get x-ray and blood tests. And those x-rays don't show us the real fundamental problem. The fundamental problem is that the cartilage has lost its shock absorption, it's thinning and weakening, not doing its job. We don't see that on an x-ray. But when we look at an x-ray and we see the space between the joints, supposed to be filled with cartilage, gone away, we by inference know that you've lost that cartilage. So that's why we use x-rays to do so. So here's a picture. Sorry for you guys who can't see it, but picture of that same healthy knee, but now an x-ray. Bone, a space between the bone. There's no space there. It's full of cartilage. Cartilage doesn't have calcium in it. Calcium deflects the x-ray beam and causes the picture not to show up on the x-ray plate. That's why bone shows up on a plate. On the x-ray, it's full of cartilage, it's full of calcium. No calcium. That picture, bone, looks like contact to contact, and the other one, that has lost all of its cushion, right? That's the classic picture. That could be my jaw, that could be my hip, my elbow, my knee. That's the loss of the space, the bone hitting the bone feeling the pressures of life instead of absorbed by the spongy cartilage, osteoarthritis. Same thing on a hip. X-ray of a right hip. This is the pelvic area, center of the body, the ball and socket joint of the hip. Relatively healthy hip there. On the other side, a very, very difficult problem called advanced hip arthritis. As a matter of fact, where's the joint? You can't hardly even see it, right? So the joint space is gone. There's no gap between there. The cartilage is gone. The bone is white. It's too dense, too much calcium in it from hypertension, actually, of the bone. More cysts in the bone spurs advanced hip arthritis. So, we now know the science. We kind of know basically what the doc does in their office to work it up. History, physical, x-ray, maybe some labs. If you've just had a tick bite, we're going to do something a little different. But if it's been 5 years of it gradually getting worse and you finally decide to go see the doc, it's probably not acute Lyme disease, okay? It's probably osteoarthritis, without any question. So the treatment goals, and this gets to the questions around the room, really, this is what we do to treat osteoarthritis. We do not cure it. We cure cancer. We don't cure osteoarthritis. We manage it. We cure it by operating on it and putting in a joint replacement, but that's the big step, right? Sometimes we do that. So our targets then are pain relief, because how does osteoarthritis of the shoulder, hip, knee, ankle, jaw, elbow affect you? It hurts and it's stiff. And we now know that we got to get the pain gone or decreased in order to do the movement to get the stiffness down or get that motion back. If you go try to do the stiffness exercises without relieving the pain, it goes the other way. And so this fundamental apprehension about using medication for discomfort, for arthritis, stops us from being able to help patients with their problem. Now we have a huge issue in this island and around the world about opioids and too much narcotics. Narcotics should not be prescribed for arthritis care unless it's sort of the end of the road. But there are many other nutraceuticals, medicines, and things that do relieve pain that we're all worried about. My kidneys, they told me once I'd get an ulcer if I took Advil. Well, yes, but 98% of people never get any trouble with Advil, and those same people are suffering from the arthritis pain. So working closely with your family doctor, your orthopedic specialist, can probably find a way to use an effective medicine to help you, but it takes education and surveillance. Okay? We good with that? Returning to function, that's what we want to do. Get rid of the pain, help you with your motion, and let you get back to doing the things you want to do. That is the treatment spectrum for osteoarthritis. So the initial treatments should be education. First and foremost, what's wrong with me? I want to know what's going on so I can process it and understand it. It can be done with your primary care doctor. Some of them love this work, others, it's not really their interest level. And so if your primary care doc really loves this stuff and they can do everything I do as a specialist, except the operations, for arthritis care. But man, I am so thankful for the world of primary care docs, because they got to do like everything. I just got to worry about bone and joints, right? They got to do everything. So it's understandable that you might not get the same amount of time and information about that when you have 12 other things that your primary care doctor is also helping you with as we get older. So, but the judicious use of over-the-counter medicines is the fundamental, most effective, cost-effective, safest way to treat osteoarthritis. People want CBD oil, they want turmeric, they want coenzyme, whatever, they want all the other kinds of things, which is fine to do. They're probably good supplements, but they don't actually treat the underlying problem. So a good conversation about that for your safety is important. Activity moderation. Hey, now, I came to you so I can go back to playing tennis. Don't tell me I've got to slow down. Well, at first, to get the pain under control, so that you can get the motion back to what's left of your joint, sometimes you do have to curtail the activity for a while and not get right back to that second activity of the day. Ice. Oh, I always thought heat was better for arthritis. Well, in fact, nobody knows. In fact, nobody's ever tested it. There are no published articles in literature or in medical school textbooks to tell you heat or ice. But there's no risk to heat or ice, as long as you don't leave the heating pad too long, get a burn. You don't leave the ice on too long, get a burn, a freezer burn. So you can try either one, but most of the time, my old pokey shoulder just is lame in the morning. My knee is just stiff in the afternoon. Heat's probably the answer. But my same old sore knee that I then went out on the boat, or I went out to Cape Pogue and hiked over the whatever, and oh, it's bad today, more than usual, ice. Ice is good for acute pain. Heat good for more chronic stiffness and lameness. So they're both important. It's not one or t'other, it's both. Home exercise, right? People come to my office, I'm probably the largest prescriber of physical therapy on the island. My practice, I couldn't without good quality, and we do, we have very blessed. Lots of good physical therapists. Very important. But what they do in the office is a piece of your care. But the evidence, the published literature, what we know to be true, is that without the home follow-through and you keeping up with that program, it doesn't really work. Big surprise, right? Not surprising. But it is one of our biggest issues or challenges. So gentle range of motion, gentle stretching is a good idea. And now to my favorite thing about this, which is a physics problem. Who took physics in high school just a few years ago here? Anybody? Anybody take physics probably? Okay. Well, there was a great formula. I'm kind of a nerd and a scientist. It was force equals stress over area. Didn't know you were going to get a physics thing. Stress, wear things out. Force, weight and activity, over area. So if the area is very large, you could put a pretty big force on it and the stress is not so high. You following me? But if you have stress that's high, overweight, and area that's low, because the joint's wearing down and is only contacting on one area now because I'm bow-legged, where my shoulder range of motion isn't very wide, so I only use it in a little area, I'm putting all that load on a small spot, the stress goes way up. So you can see someone who comes in with mild arthritis and in months, the joint's gone. Once they get out of balance, and there's too much stress on the joint, which is force applied to there. So weight loss, that's the physics. Weight loss is the second real treatment for osteoarthritis. Even for the shoulder, it's not just hip, knees, and ankles. Weight loss helps your joints function longer. There's a whole bunch of science behind that, but it's true. So that's not new, but it's definitely true. Okay, we doing all right? We're touching on the topics? Okay, good. So the second, doctors think of first line treatment, so the second line treatments and third line treatments, sometimes a lot more. For orthopedics, don't tell anybody, my job's not that hard. First line treatment, second line treatment, third line treatment, that's it. Okay? Primary care docs, woof. They got zillions of things. Orthopedics, not that complicated. Second line treatment. Guess what? We're back to pain relieving medication again, but it might be a different formulation or a prescription level, not narcotic, but a prescription level, carefully administered, thinking about your other health conditions, stomach, kidneys, liver especially. Oftentimes with an antidepressant, not because we're all depressed in the world, but because chronic pain does affect your mental health. No question about it. There's sort of a stigma of depression. That's not what we're talking about. We shouldn't have a stigma at all about depression. But it's real when it comes to chronic pain. I can assure you. For 15 years, eventually sleeping in a chair, not even being able to walk, much less play tennis for me, while I was waiting for kids to get through college before I had my hips replaced, it wears on you. And so not only is there an antidepressant effect for the depression, but it also affects the same kind of nerve transmission that arthritis nerve pain goes through. And so your family physician may well talk to you about a combination of those. And the National Institute of Health has published a beautiful thing called the Arthritis Ladder, and on it has a whole spectrum of medicines that we've been giving to all the primary care docs. So we broaden the depth of our conversation we have in the office. When you come in, I can give it to you. Next is physical therapy. We talked about, I'm just going to stretch my elbow or do it at home, but actually professionals, physical therapists, starting for two visits a week. You don't want to do a lot more. Joint will hurt too much. It's a little bit of education, a little bit of home exercise, couple 3 weeks. Sometimes they do ultrasound treatments to get the inflammation down to the sore shoulder, the Baker's cyst, the ankle, whatever. But then they'll give you a home exercise program to help maintain the motion and strength. Because here's the other true. A weak arthritic joint is more symptomatic than a strongly supported arthritic joint. Muscles operating around a joint cushion the joint. I've lost my main cushion because I have this disease called osteoarthritis. I've lost my main white cushiony cartilage, beautiful pearly white cushion. But those muscles also help cushion the joint dynamically. So therefore, a consistent home exercise program can really help quite a bit. Sometimes all at the same time, sometimes independently we'll add medicine, not by mouth, but in the joint. Who in the room has had, if you don't mind, HIPAA violation, but who's had a cortisone shot? Anybody? Me? A couple people. What is that? Very potent, anti-inflammatory, made in your body every day. There's just factories that also can make it remarkably. Very inexpensive, really safe when used in joints by a learned person who knows how to put the medicine in the right place. Not every week, not every day, but can be very helpful for an acute flare of arthritis. I've been living with this knee for years, Doc, but I have got to go. My daughter and I are doing the trip of a lifetime to Rome, and I need 2 weeks worth of knee pain. Cortisone shot. You'll feel like you have a very good chance of having a better trip and enjoying that trip. Not a lifelong cure, not going to solve anything, but can be very helpful. $1 sign. Effective, inexpensive. It's a good combo these days in healthcare in this world. Other kinds of injections from hyaluronic acid. There's 5 of them in the United States. It's a lubricant, synthetic lubricant, lasts about 5 to 7 days in your knee. It's gone, but it regulates, turns down the volume of the inflammation longer than cortisone. Guess what? Quite a bit more expensive. Your own cells spun down in the laboratory and given back to you. We do that in our office. Platelet-rich plasma, more expensive, lasts longer than cortisone. Maybe actually one of the new frontiers, not yet paid for by health insurance companies. Why? Not enough science yet, not proven literature by peer-reviewed physicians, but coming, available here because we want to be able to offer it to our patients, but with a lot of conversation. $2 signs, $800. Wow, $800, holy cow, that's like a month spend. Okay, got it. Yeah, think about it. Finally, stem cells. Anybody heard of the conversation around stem cells? Well, we talked about it here. Gonna be spectacular, probably. But right now, still a wild, wild west when it comes to the use of stem cells for arthritis conditions. You can get in a jet, fly to Sun Valley today, and you'll find somebody, $30,000, they'll give you 5 injections of stem cells and send you on your way. Some people get remarkable benefit from that. Some people get no benefit from it. Beaucoup dolare, no evidence. No published good quality evidence. Our academy, the American Academy of Orthopedic Surgeons, I had the privilege of being the president last year, has had a really big coming together of people worldwide at Stanford last year, writing the first sort of paper about what's the science. In my lifetime, maybe, in my children's lifetime, likely, we won't be doing what I do for a living very much, which is artificially putting in new metal and plastic joints. We probably won't do that. In your lifetime, probably not going to have the wide use safely of stem cells, sadly, for this problem. Might be for brain cancer, unbelievable. Might be for other cancers, maybe. Yes, happening today. But for bone and joint things, a little bit of very new, unknown if it's true. Okay? Here was one of the questions that came up. How about nutrition and supplements and things? I just like that picture. I think it captures the topic, which is lots of them, kind of a funnel, and that encapsulates the idea of low harm, unknown benefit. We actually don't know if taking glucosamine helps, but I can tell you, you know what I mean? Glucosamine, those supplements, or some of the other turmeric, anti-inflammatory. I have patients who come in and swear by it, and I'm like, yay! And they ask me, is it safe? And I go, don't know. Because I don't know. So I just got to tell you, I don't know, because there's no published literature on this stuff. But some people come say it's great, and it's a little more than just placebo. Placebo meaning sugar pill, no risk. I feel better. And that's great. That's very powerful. It's been great for 3,000 years. But that's really where this is. And I'm not like anti-supplements. I take them myself. But I don't know if they're good for me or not. But I know their harm is very low. A little bit for some of them. There's a biopsy of your wallet these days for some of these things. So a little bit careful about that. But, you know, chat with your family doctor. Chat with me, anyone. Dr. Navy, Anthony in our office. We'll try to give you what is there. Probably no harm. May be beneficial if you believe in it, probably a better chance of it helping you. And there's a lot of science, a lot of medicine that's that way, and that's just fine. Specifically, back in 1985, glucosamine, chondroitin, that combination, we've got it. We have the answer to early arthritis, pain gone. Those studies were miraculous. It was like 85% of patients feel good, 1985. They're good. Maybe we figured it out, finally, the number one ailment in the world for loss of work and everything else. When they finally did it in a study that was funded by the National Institute of Health in the United States, no benefit. Unfortunately, though, all of those studies were funded by industry. You gotta love pharmaceutical companies. They're good, right? Most of them, there's some price and all those issues, but where does the science that we're living longer lives comes from? They're not bad, but they have an interest, right? And that biases the data. So without that bias, 50-50 chance whether you're going to get benefit, but very low risk, why not try? If it's something weirdo that isn't mainstream, or like only your grandmother up island uses and I use that, just make sure you tell us when you come into the hospital for something serious, because that may have a very significant impact on a medicine we need to give you, or a surgery you're having emergently, like a gallbladder or something, and we don't know you're on St. Robin's route, right? And that may thin your blood dramatically. And then you bleed seriously from what should have been a no big deal operation. Just be really honest about what you are taking to help us help you. CBD, oils and pills, that whole spectrum, there's definitely something there, no question. Pain relief, nausea, general wellness, we don't know what it is. We don't know how often to take it. We don't know if you take it with something else, is it good or bad? So you can't say, the doctors know, because we do that all the time as doctors, especially in North America. We have no idea, quite honestly. If we're honest, we just say, Wild Wild West. And I'm a pilot, like I said, and if you feel comfortable being a test pilot, then go have fun and use on your body or in it what you want. I don't mean to be glib about that, because it's probably little risk, quite honestly, little risk. There has now been some published papers that people who take a lot of oral CBD actually have problems. So if you're going to try it, just tiptoe in those waters and seek help from an expert. And I am not that. There are some nutrition people, homeopathic specialists, people of other complementary medicine disciplines on island and off island and on the web, warning, on the web, where you can get some information. But the one true of this is that there's no Food and Drug Administration oversight. You can have a comment about what the Food and Drug Administration in the United States is all about, but there's no oversight. You have no idea what's in that bottle. And you have no idea what's in that bottle. I guarantee you do not. And the ones that came in from Argentina had rat poison in them. They had cumin in it. They had warfarin in it. And it was being sold as that. So just careful, be warned. That's all I can really say. So I'm sort of done of the formal non-surgical part, which I think was the method here, what we got from asking you all about it. So the real question is, if you've tried some of these things that we talked about, and you're still having more disability, loss of joie de vivre, and you want to keep going, then there are options surgically to help with your problem that can really be definitive and life-changing. So it's balance. That's why it takes a conversation. This doesn't happen in an 8-minute classic, 8-minute orthopedic visit. This takes time. Maybe more than one visit, maybe 3 visits, because we're dealing with a chronic disease. Most people don't think of arthritis, osteoarthritis, as a chronic disease. But it absolutely is. There's a pathology, there's a breakdown of the cartilage, that enzyme's not doing its thing, that one's doing too much, that one's doing whatever. There's pathology there, it's a disease, just like cancer, heart disease, hypertension, diabetes, it's a disease. So you have to sort of have a conversation around the management of that whole thing. But it is one of the very few chronic diseases that's curable. So this big warning flag here, salesman, orthopedic surgeon, okay, warning, but this chronic disease is curable. It just takes the surgical realignment of the joint and resurfacing of the joint with material to make the pain go down. So that's the short version of hip replacement, knee replacement, shoulder replacement, elbow replacement, ankle replacement, thumb replacement, all those different things that we do. So parting shot here is that the American Academy of Orthopedic Surgeons, the organization I've been able to volunteer with for 20 years, does have a whole series of good things on the topics that I just talked about, if you happen to like to use the web. It's a pretty easy website. It's called orthoinfo, catchy little name, .org, orthoinfo.org. And it has everything I said and more, and some of these slides, and lots of good things. But particularly, if you go to orthoinfo, there's some pages that are called Education for the Informed Patient. And it's actually free, no password. We will not ask you to sign up for anything. It's no money, it's free. You can access and take online about a 20-minute look, ask you about your symptoms, what you've done, what you haven't done, what your preferences are, and then you'll come up with sort of a grid of the things to print out and take to your doctor at the appointment and say, hey, I want to talk about these things. And it can make the visit a little more efficient for you to get your questions answered rather than what Dave Halsey wants to talk about that day. And if it's about fishing or my boat, I guarantee that's what I want to talk a little bit about. The more I want to talk about, the history of the island, the people here, and your bone and joint condition. So that's what I've got sort of canned. We okay on time? We're right at the top of the hour. I'm here for as long as you guys would like. If you have some questions, Baker cyst and other more directed things, but I wanted to get sort of the basics out so that we're all a little bit more knowledgeable after our tummies are filled, and I'll be happy to try to help out individually or as a group anytime. Thanks for the chance to be here.